Good morning, Ray.
Good morning, Dr. Bischoff. How are you?
Very good. How are you?
Pretty well, thank you.
Are you seeing my screen?
Perfectly, yes.
Okay. Ray, should we move to the regular session so we can see countries that are joining?
Yes, we can do that. Yep,
Perfect. How are you?
pretty well.
Good.
We can do that right now. Here we go.
Good morning, everyone, and welcome to our International Colorectal Web Meeting. Today, we're going to focus the entire session on how to do and how to interpret the high-pressure distal colostogram. This is the most important study prior to the repair of a male patient with anorectal malformation. I asked you all to type in the chat where you're joining us from. So today I didn't get much response, but I know we have people from Yemen, Pakistan, Saudi Arabia, and Hong Kong. So if I didn't mention your country, please type in the chat and I will acknowledge at the end. So the high pressure distal colostogram will be done in patients that have had a colostomy during the newborn period. And for anorectal malformations, we recommend a descending divided colostomy. So we're gonna see an animation. The size of the Foley that we're gonna use in the mucus fistula will depend on the size of the mucus fistula. We recommend tapering and making a small mucus fistula. So we usually use a number 6 French Foley. Let me just advance my slides. And then we're gonna see the animation. So we insert the Foley into the mucus fistula, and we inflate the balloon and we pull back to act as a plug. We're gonna inject contrast material under fluoroscopy, and you have to keep injecting to overcome the pressure of the muscle. Keep injecting so you feel the bladder, and you keep injecting and the patient will pee, will void. So that's the perfect image of the distal colostogram. You always have to tell the radiologist that you want to see the mucus fistula entrance that will be guided by the balloon. You want to see the sacrum. You want to see the connection of the rectum with the urinary tract. And ideally, you want to see the urethra. That would be the perfect distal colostogram.
Can I say something?
Yes.
Can you repeat the?
Yes.
Please notice. Please notice that when the contrast material is injected, the contrast material stops at the level of the pubococcygeal line, stops there, and it requires high pressure in order to go through the fistula. So if you don't put pressure, then you have a false image of a higher malformation. Repeat it again. Again, with the injection, the contrast material goes down, but always stops at the level of the pubococcygeal line, right there. And it requires high pressure. That's why we call it high pressure distal colostogram to overcome the muscle tone of the sphincter mechanism. Now you see the real image. So that's the key part of the study. And that not understanding that principle is the source of many misdiagnoses and, as a consequence, misadventures in operations in anorectal malformations.
So when the other thing is, if you don't have a good sacral x-ray, that's a good opportunity to start. We always start this study, you need an anal marker, a radiopaque marker at the anal impression where the anus should be located. And ideally, we start the study with the patient laying supine in the table and you inject so you can see how much bowel you have. Once you feel the entire bowel, then you turn the patient in perfect lateral and continue the study. A frequent mistake done by radiologists is to have the patient in oblique position. We want the patient in perfect lateral because we're going to enter exactly in the midline, and our reference point is the sacrum. So we need to see exactly where's the sacrum in relation, where's the bowel in relationship with the sacrum. So if you don't have a sacral ratio, that's a good opportunity to obtain good sacral images to calculate the sacral ratio. So now we're gonna see, this one was one of the first patients I operated here in Denver. So the distal colostogram was not done by me. And here you can see one of the mistakes. So this is how we start the study with the patient in supine. We're injecting contrast. So just by looking at this image, we know that the surgeon did not clean the distal bowel. That's something you should do during your colostomy opening. And then once you feel the bowel, you're going to turn the patient in perfect lateral. But here they did oblique image. That's what we don't like. But here, look at this image. And even when it's not a perfect lateral, this is a patient that I can tell with Down syndrome. So look at this distal colostogram and let's try to answer which malformation is this. So look carefully. Is this a rectoperineal fistula, no fistula, rectourethral bulbar fistula, rectoprostatic fistula, or rectobladder neck fistula? Everybody can vote. And again, this is not an ideal one because it's not perfect lateral, but I gave you a very good hint. Everybody can vote. And very good. So this one, I agree, it's a difficult one because it was not done perfectly. So I think we could inject more pressure here, but this was a case of no fistula. It was a patient with Down syndrome.
Can you say, let me criticize this. And the image, this image that is taken oblique doesn't allow the surgeon make a plan. The operations to repair anorectal malformation should not be exploration, surgical exploration to see what you find. When surgeons approach a patient with an anorectal malformation and they don't know the specific precise diagnosis, they start looking for a rectum that may not be there, and instead they may find structures that you don't want to find, such as nerves that innervate the bladder and the penis, and such as vas deferens and seminal vesicles and prostate. So with this image that you are seeing here, and oblique, you don't know where the rectum is because you don't have the basic reference. Remember, you approach the patient posterior sagittal, so you take as a reference the sacrum and the end of the sacrum, the coccyx. In order, with a good study, you know exactly what you are going to find when you approach the patient. In addition, they did not put a marker in the anal dimple, so you don't see the tip of the coccyx. It's a very bad study.
So now we'll have a few that I was present to do it. So now we're going to start to see better studies. So look at this one. This one, I was present to do it. You can see that there is a radiopaque marker here. You can see the end. You can see the coccyx. So what type of malformation is this? Look carefully. Is this a rectoperineal fistula? Is this a no fistula? Is this a rectourethral bulbar fistula, rectoprostatic fistula, or a rectobladder neck fistula? And of course, it's easier to know when you're doing the study yourself because you can actually see where the contrast is coming out. But just let's see. Very good. This is a rectoperineal fistula. So this is those rare cases in which there is a long, narrow rectoperineal fistula. And for most of these cases, when it's a rectoperineal fistula, you don't need a distal colostogram. But in this case, the rectoperineal fistula was not seen. The patient came from outside. We met the patient at the table for the radiological study, and we were able to feel the tract of this narrow rectoperineal fistula. But when you do those studies, you want to know, as I enter posterior sagittally, what am I going to find? Am I going to find the rectum? Do I have enough bowel to bring this to the center of the sphincter? So I have all the information, and I know that when I enter, and again, because I was present, I know that this was not the urethra. I saw where the contrast was coming from. So this is a rectal perineal fistula. It's a rare case where you have a long, narrow fistula. Now let's look at this study. So again, here is the mucus fistula. Then we have the bowel that goes like that and opens here. This is the bladder. This is the anal marker. So look careful and tell me what malformation is this, and everybody will get to vote. Rectoperineal, no fistula, bulbar, prostatic, or bladder neck. Everybody can vote. Let's see the answer. Haha. This one we have some people thinking it's a bulbar, the majority thinking it's a prostatic, and some people thinking it's bladder neck. So that's the importance of reviewing all those images so we can all agree upon definitions. So I would say, and we have to remember that we classify malformations, but malformations also come in between. So I would say if it opened here, it would be bladder neck. In that straight zone, prostatic. In this curve, bulbar fistula. So this one, I would consider a low prostatic. So I would consider this a prostatic fistula. And you can see that the distance from the anal marker, a bulbar fistula would be closer to your anal impression. This one, you have a long way to go. Dr. Peña, do you want to comment? Sometimes when we find the rectum very close to the tip of the sacrum, how you find it?
Where is the tip of the sacrum? Yes, you see, always when the surgeon is going to look to this study, and this looking at the sacrum, the image is not very good, but the coccyx is about here. So the operation of the surgeon is going to be, an incision is going to be from here to here. So he has to go under the coccyx looking for the rectum to find it. If he goes straight here, without a distal colostogram, he will not find the rectum, he will find the urinary tract. So that's why you during the operation, you are palpating the coccyx, which is, I think it's here. So you know that you open here, but you have to go under the coccyx looking for a high rectum. And the prostatic fistula is a malformation that requires a significant mobilization of the rectum in order for the rectum to reach the perineum. But it's very important to, in the first film, the AP film, to see if you have enough length of bowel in order to mobilize these down. That's very important information. That's the first piece of information that we get from a distal colostogram. In AP position, how much bowel is available between the mucous fistula and the end of the bowel.
So this is a rectoprostatic fistula. So now let's look at another image. And again, you can see that here's the end of the sacrum, here's the bladder, here's the urethra, here's the anal marker. So what malformation is this? Everybody can vote. Is this a rectoperineal fistula? Is this a rectobulbar fistula, a prostatic fistula, or a bladder neck fistula? Everybody can vote. And let's see the answer. Majority said this is a bulbar fistula, some said prostatic fistula, and still some people thinking this is a bladder neck. So let's look again. To be a bladder neck, I think we have to understand, to be a bladder neck, the rectum would have to open here. So this is definitely not a bladder neck. There should be no confusion on that. And here, if the rectum is open in this region, would be prostatic. If the rectum is opening in the curve, would be a bulbar fistula. So this one you can consider either a high bulbar or a low prostatic. I would accept both because you can see there is a long distance between the rectum to the anal marker. You can see that the rectum is a little higher than the end of the sacrum, but this I would probably classify as a bulbar because I see it right at the curve. But if you want to say it's a low prostatic, we could accept. But bladder neck, no way. This is not a rectal bladder neck fistula.
Now, it's very important. If you were present, if I was present in this study, you can see that the contrast material came in the rectum and then went up into the bladder because we see the contrast in the bladder. So, and if you keep injecting, the bladder will get fuller and fuller, and eventually the patient will start urinating, peeing, passing urine through the urethra, and then you will have a beautiful picture that shows the rectum, the bladder, and the entire urethra. And then that will facilitate you to be more precise in the diagnosis. Now, even if you cannot make a precise diagnosis between bulbar and prostatic, with this study, you have enough information to operate on the patient because you have the sacrum here, the coccyx here, and you know that you will have to enter and look a little higher here to find the rectum. So, but it would be beautiful if we could have seen the entire urethra here. And when the patient is peeing, that's when you must the radiologist must take a picture, the opportunity to see the entire picture. I hope we can see, but the good part of this study is that it's perfect lateral. You see the patient has both femurs together and both hips overimposed. So this is a perfect lateral theme. That's the good part.
And this is, we'll have a better colostogram to show, but I know you have all been in a situation in which you pass the Foley and then you find the Foley inside the rectum. So it's looking at this image, you can see that if you pass the Foley, sometimes it's easier for the Foley to enter in the rectum than to make this curve and go to the bladder. We'll have a better image to show that, but that's how it happens. Now let's look at this image here. So make sure you see where's the sacrum, where's the anal marker, where's the mucus fistula, and we're gonna answer what malformation is this? Rectoperineal fistula, no fistula, rectourethral bulbar fistula, rectoprostatic fistula, rectal bladder neck fistula. Everybody can vote. And I hope this one we will get, yay, 100%. Very good, no fistula. And the key to know if this is truly a no fistula case is that you have to see that the bowel is distended and it should be close to the anal marker at the level of the bulbar urethra. So it should be distended, round, and close to their anal marker. Then you know it's a real study, because one of the mistakes is not finding the fistula and thinking it's a no fistula.
Now, this is a study that the radiologists must be congratulated for doing this study, because you can see that the radiologists in this study use significant hydrostatic pressure. Look at how distended is the rectum. Remember that the PC line, from the PC line down, all this rectum is surrounded by sphincter, like a funnel-like sphincter, and keeps closed the rectum under normal circumstances. So in order to achieve this image that you can see here, the radiologists use significant hydrostatic pressure. In addition, it's a perfect lateral. And now, the fact that the patient has no fistula, you can say this most likely is a Down syndrome baby. And in the anorectal malformation, in Down syndrome babies, the rectum is always located this low.
Now let's look at another study. So see the mucus fistula here. That's the injection of contrast. This is the urethra. This is the bladder. This is the urethra. and this is the anal marker. So let's answer the question of what type of malformation is this? Rectoperineal, no fistula, rectourethral bulbar, rectoprostatic, rectobladder neck fistula. Everybody can vote, and let's see what's the answer. Very good. So the majority said rectoprostatic fistula. We still are having someone saying rectobladder neck fistula, or some people saying rectoperineal fistula. Those are big mistakes. So rectobladder neck fistula would open here. This is a prostatic because it's opening in the middle of the urethra, and you can see where is the end of the sacrum. So those are hard cases. You really have to have experience to find the rectum above the sacrum. And then in this case, I would be concerned because I'm not sure if we'll have enough bowel to bring this all the way to here. Dr. Peña, do you want to discuss the options? The key is to be prepared. So you have to be prepared that you're going to have a short bowel to bring this all the way to here. So what are our options?
Remember that the first piece of information that we try to get in a distal colostogram is how much bowel we have from the mucous fistula to the end of the bowel, and whether or not we have enough length to be able to bring this piece of rectum all the way down here. Now, you don't have to be a mathematician or a physicist, a rocket science expert to know that this is a very short rectum. One of the most common errors in opening a colostomy is to open the colostomy too distal, which means that the surgeon will have problems bringing this rectum down. So that's why we insist that the colostomy should be done in the descending colon, not in the sigmoid, because this is a consequence of doing it in the sigmoid. Now, what happens if you see a patient like this and you are going to operate on him? Number one, you have to look for the rectum. You can see the coccyx here. You have to go under to find a very high rectum. You have to be prepared to look for the rectum very high, and it's not going to be an easy mobilization. And chances are that even if you try to mobilize, you will not be able to bring the rectum down. And in those circumstances, you must be prepared before the operation, because you are aware of this potential problem. You're supposed to clean the entire proximal colon, clean the colon before the operation, in case you have to use it, just as a precaution, and clean, of course, this distal bowel. And then go into the abdomen, and you enter in this operation with total body preparation to be ready to switch from the perineum to the abdomen and back to the perineum. And then you disconnect the mucous fistula and see if that helps you to bring the rectum down. If that's not enough, if that's enough, you bring the rectum here, but then this part of the bowel is going to be left inside the abdomen, will not reach the abdominal wall. And you leave it there with a mark with a big silk stitches, and you keep that in mind. At the time of colostomy closure, you have to look for that bowel, distal bowel, deep in the pelvis. So sometimes this piece is so short that you cannot do that. It's so short that you bring the rectum down, but then you leave the distal end very, very, very low. And for that situation, you have one alternative is to close the colostomy and pull more bowel from above. But for that, you have to be prepared. So that's the importance of the distal colostogram. You're not supposed to have surprises in the middle of an operation.
So when you're faced with this scenario, you can take the mucous fistula and move it lower in the abdomen, if feasible. You can close the colostomy, pull through, and leave the patient NPO for 7 days, or you can close the colostomy, pull through, and open a more proximal stoma. But you really have to be prepared. That's the key. Now let's look at this other distal colostogram. So again, we're seeing the mucous fistula, then the bowel goes around, come in here. This is the sacrum, this is the anal marker, and you can see a hint of the urethra. Everybody can vote. What malformation is this? Rectoperineal, no fistula, rectourethral-bulbar fistula, rectoprostatic fistula, rectobladder neck fistula. And let's see the answer. Rectourethral-bulbar fistula. So whoever answered no fistula was not paying attention, because I even mentioned that's the urethra right here. And if you see this beak, when you're injecting pressure and you see that it's forming this beak, it means that it has a fistula. So you have to continue injecting. And in this case, you can see that the urethra is here, and you can see some contrast starting to fill the bladder. But at this point, the baby was already uncomfortable. I felt I have enough information, so I didn't continue to inject. That's the importance of the surgeon being there and say it's okay to stop this study, because I know that if I enter posterior sagittally, I'm gonna find the rectum. I know I have enough bowel for the pull through, and I saw the connection, so I was happy to stop there. Of course, if I wanted the perfect study, I should continue injecting, but I felt I had all the information that I needed.
Now, look at this study, and it's a perfect lateral image, which is great. Now, somebody will believe that the patient was born with a very narrow piece of rectum here. That's not true. Actually, this shows is the effect of the sphincter mechanism compressing this distal rectum. Actually, this rectum is as wide as this all the way down here, except that it's compressed by the muscle. Now, the question is, sometimes the contrast material, by the way, the contrast material should always be
Hydrosoluble.
Hydrosoluble contrast material. Do not use barium. Do not use barium. So the contrast goes into the urethra, and sometimes, most of the times, goes up into the bladder, but all the times it goes distal into the urethra. And the question is why? Well, here's the answer. If the rectourethral bulbar fistula, most likely the contrast will go into the distal urethra. There is something called the external urethral sphincter. The urologists know that term, because when you do a cystoscopy, you see an area where there is some sort of contraction in the urethra. That is usually in the bulbar urethra. So that's why when you in a bulbar fistula, the contrast, the rectum is located distal to that sphincter, and the contrast will go through the penis. Whereas in prostatic fistula, the contrast material will go up into the bladder because the sphincter is below the location of the fistula. So this is a beautiful study. You know, when you enter, you will go very confident, very happy. Enter here, you just go deeper and you find the rectum. There is no way for you to injure the urinary tract unless you are completely disoriented.
Okay, so here's another study. So again, this is the mucus fistula. We're injecting contrast. This is a hint of the bladder, and this is the urethra. So and here you can see the anal marker. So what type of malformation is this? A rectoperineal, no fistula, rectourethral bulbar fistula, rectoprostatic fistula, or rectobladder neck fistula? Everybody can vote. Rectourethral bulbar fistula. Okay, we have some people saying perineal and some people saying prostatic. Yeah. So perineal would have to open close to the anal marker, so the angle would be different. There is one malformation that is very rare, that it's a rectoperineal fistula that goes parallel to the urethra. That's not the case, because then it's very thin. Here you can see really the bulbar urethra that is very big, and you can see the entire urethra here, and here is the bladder. So this is a rectourethral bulbar fistula. You can see that entering posterior sagittally, you're gonna find the rectum, and the distance between the rectum and the anal mark is small. It's about 2 centimeters.
And again, the surgeons who opened this colostomy opened the colostomy too distal. left a very short piece of bowel, but fortunately, it's a vulvar fistula. In a vulvar fistula, actually, the amount of mobilization of the rectum is minimal, so I can predict that this will reach easily the perineum. But again, the surgeon, if this was a prostatic, the surgeon, like the fistula was here, it would be, with this piece of bowel, it would be impossible to reach the perineum. So when you open a colostomy, don't forget to open the colostomy, the descending colon, be sure that you leave enough bowel distal, and be sure to irrigate and clean completely the distal bowel so you don't find stool in the distal bowel during the repair.
So here's another one. So we are injecting contrast material here. Then you see we have plenty of bowel goes here and here. And here you can see where the sacrum finishes. So what malformation is this? Rectoperineal, no fistula, bulbar, prostatic, or bladder neck? Everybody can vote. Wow, we have everywhere, rectoperineal, no fistula, bulbar, prostatic, and bladder neck. The majority are right, prostatic. So let's look at the contrast study. Again, when you see a long distance from the rectum to the anal marker, you have to suspect that you're dealing with a higher malformation. In this case, we see the urethra here. So here would be bulbar urethra. We're not seeing well the urethra, but for me, this is a rectoprostatic fistula because I will find the rectum above the sacrum. So this is a rectoprostatic fistula, but we'll know we have enough bowel.
You see, the radiologist did a good job, put the patient in perfect lateral position, but did not insist in putting more pressure in order to see the urethra better. This is the urethra, but it's very, if I was there, I will keep injecting to have a better image, or take a video. In a video, you see the contrast going through the urethra, but see here, you can see the urethra going all the way down here. So, and the bulbar will be in the curve. Remember here in the curve will be bulbar. This will be prostatic. And they did not inject enough pressure to see the bladder.
Yeah. So I was there in this study. The problem is when you have too much distal bowel, in this case, you can see that you have a lot of distal bowel. So I injected significant amount, and this portion of the bowel was very distended already. So when babies start getting very uncomfortable and I have enough information, I usually stop the study, because all what I want is I need to know, where's the fistula? Do I have enough bowel? So if I am present and I have this information, I stop, because I was concerned to keep injecting since this distal bowel was already very distended and the baby was very uncomfortable already. But this is a rectoprostatic fistula. Okay, so another study. Here is the mucus fistula. We're injecting contrast. Here is the bladder. It's almost like a triangular bladder. And here is the urethra. So what malformation is this? Perineal, no fistula, bulbar, prostatic, or bladder neck? Everybody can vote. And let's see the answer. We have divided audience between bulbar, prostatic, and bladder neck. I think I'm okay with the question between bulbar and prostatic, but I'm not okay with bladder neck. This is not a bladder neck for sure. So you can see the anal marker here. The baby is moving. That's why you got double images. If it was bladder neck, the rectum would open here. If the rectum opens in that area, it's a prostatic. If it opens in the curve, it's a bulbar. So this is between a bulbar and a prostatic. So if you say high bulbar, I would accept. If you say low prostatic, I would accept. But I would not accept bladder neck nor perineal. So yes.
No, my complaint about this study, I will tell the radiologists, you know, we have to see the sacrum and the coccyx well, because that's our reference for the operation. And something happened with the technique, the radiology technique, that you can hardly differentiate soft tissues from bone. So I will demand that they change the technique so I could see exactly the sacrum and the coccyx. So, and again, why people keep talking about rectal bladder neck? Rectal bladder neck, you have to see the bladder and you have to see the rectum opening right here in the bladder neck. So please don't insist, look carefully. D will be bladder neck, prostatic will be around here, and bulbar will be where there is a curve of the urethra, but unfortunately they didn't show the bulbar urethra here.
So usually when we do the studies, we also get an actual X-ray, and then this is white, and then we see the sacrum really well. I just had to select the images that showed the fistula better. So that was the one I selected. Okay, what about this study? So we can see the mucous fistula. There is plenty of bowel. What type of malformation is this? Rectoperineal, no fistula, bulbar, prostatic, or bladder neck? Let's see what people vote. Let's see the answer. So this one, the right answer would be, I don't know, because this is a study that we did not demonstrate the fistula. So you can see the sacrum here. You know you will find the rectum. You know you have enough bowel, and the bowel is pointing towards a fistula, but I don't see the fistula. So if I had to bet, I would say this patient has a fistula, but this is not an adequate study, and you almost see this flat line. That is the muscle tone. So I don't know what malformation is this, but if I could suspect, I would say this patient will have a rectal urethral fistula, either prostatic or bulbar, but I don't know what type of malformation this is. So ideally, this study was not done here in our hospital. You can see that the marker is different. We always use the arrow. I did not repeat this study. This patient was coming from a different town, and I had the information that I needed, that this patient have a fistula. I could bet money on that. I had enough bowel, and I know that if I look close to the end of the sacrum, I would find the bowel. So I did not repeat the study because of that, because I had all the information that I needed, but this is not a well done study. You want to comment?
Yes, in this study, it would be beautiful if the radiologists continue applying hydrostatic pressure, and suddenly we'll see the contrast material going to the bladder or going into the urethra, and then we'll have the precise diagnosis. As Dr. Bishop said, on the other hand, the study is perfect because it's a lateral film, and you can see the sacrum and the coccyx, and you have enough information to know that when you enter, you have to go a little higher to find the rectum. It's a beautiful study, but again, with more pressure, it will be even more beautiful.
Now let's look at this study. So here is the mucous fistula. You can see you have a lot of bowel, and then the distal bowel is distended. Here is the sacrum. Here is the anal marker. So what malformation is this? Perineal, no fistula, bulbar fistula, prostatic fistula, bladder neck fistula. And again, people still voting bladder neck and perineal. So this is a bulbar fistula. Let's look. So here you can see the bladder. So if the rectum opened here, it would be bladder neck. If the rectum opens in this area, would be prostatic. If the rectum opens in the curve, this is a bulbar fistula. You can see that the distance is not that high. So you can say a high bulbar. I could accept a low prostatic, but in this case, I would say it's a bulbar. And but not bladder neck, not perineal. We're feeling the urinary tract, so it could not be a rectal perineal fistula.
But for those who are saying perineal fistula, please listen carefully. A perineal fistula is the rectum will open here in the skin, Number one, if we make the diagnosis of perineal fistula clinically, we don't do distal colostograms. In addition, if we make the diagnosis of a perineal fistula, we do not open colostomies. So again, but if the patient already comes with a colostomy and the perineal fistula is so tiny that everybody misses the orifice, sometimes the patient has a distal colostogram, but then the distal colostogram, you will see the fistula opening here. So that would be a perineal fistula in the perineum, and the contrast will come out of the baby. So here, fortunately, you can see the curve of the urethra right here. And when the rectum opens in the curve, that's a bulbar fistula. Prostatic will be sometime here, and bladder neck, we cannot make that diagnosis because we don't see the bladder. For that, the radiologist should keep injecting, hoping that the contrast will fill the bladder, and then you will have the diagnosis of bladder neck. This is not a bladder neck.
Okay, this is another study. So we don't see the mucous fistula very well. And I want to know if anybody has any idea why this study is so different from the other studies that we have done. So you can say what malformation is this, and then I'm going to discuss what happened in this study. Perineal, no fistula, bulbar, prostatic, or bladder neck. Everybody can vote. Bulbar, prostatic, and bladder neck. Okay. So this patient was born, had a colostomy by another surgeon, and the mucous fistula closed. So when they went to do the distal colostogram, they couldn't because there was no mucous fistula. So what did they decide to do? Do avoiding cystogram. So that's why we don't know how much bowel we have here. That's a very important piece of information. And that's one of the reasons why we don't like voiding cystograms, to tell us where the fistula is. So, but here you can see the bladder. Here you can see the curve. So it's not a bulbar fistula, and you can see the connection right here. So this is a rectoprostatic fistula. This, when you look at this study, you have to think that the rectum will be a little lower than what it's showing. Here you can see the end of the sacrum, because we're not injecting pressure from above. So that's why we're seeing the rectum so high. But in this case, I have no idea how much bowel the patient has. So that's why this is not the right study. So this one, I was invited to just help the surgeon. So he guaranteed to me that we had enough bowel, and we did, and it was a rectoprostatic fistula. We also confirmed with cystoscopy before the case. But that's why this study is so different than all the others.
So remember, some surgeons believe that, and radiologists believe that a voiding cystourethrogram is a good study to determine the location of the fistula. Sometimes the voiding cystourethrogram shows the fistula. Most of the time it doesn't. So voiding cystourethrogram is not the adequate study to determine to make precise diagnosis in anorectal malformation.
Okay, now next one. So look at the sacrum. This is the anal marker. This is the bladder. So what malformation is this? Rectoperineal, no fistula, rectobulbar, rectoprostatic, or rectobladder neck fistula. Everybody can vote. Okay, this is not a case of no fistula because we are seeing the urinary tract. So no fistula is not an option. Bulbar in this case is not an option. Bulbar would have to be in the curve of the urethra close to the anal marker is not an option. For me, this is a very high prostatic or a bladder neck. This is a very high malformation. If the patient has a normal sacrum, you could potentially try to find it, but this is one that entering through the abdomen, through laparoscopy, it's actually a good idea because it's gonna be very high. So I would consider this for purpose of surgery and functional prognosis. This is a rectal bladder neck fistula. If the bladder was filled, you would see that. If you want to say a very high prostatic, I would accept that too. Can I comment? Now let's look at this one. What malformation is this? Rectoperineal, no fistula, rectourethral-bulbar fistula, rectoprostatic fistula, or rectobladder neck fistula. And you can see the distal bowel. You have plenty of bowel. Here you can see the coccyx. So you know that entering you're gonna find, and then you see the urethra. So again, if this was a rectoperineal, as Dr. Pena showed before, it would open right here, right before your anal marker, okay? So this is a rectourethral-bulbar fistula. It's feeling directly the urethra here. It's not feeling the bladder, it's feeling directly the urethra, and the space is very short between the rectum and the anal marker. Wanna comment? So let's see another one. So this is a rectourethral-bulbar fistula. Unfortunately, this one, I tried to remove this measurements, but they made in a way that I could not remove. So it's not an ideal study. But here is the mucus fistula. Here you can see the bowel and it opens here. And here you can see the bladder. So hopefully you can tell me which malformation is this. Rectoperineal, no fistula, rectourethral-bulbar fistula, rectoprostatic fistula, or rectobladder neck fistula. So let's vote. Rectoprostatic fistula, very good. So unfortunately, this is right where we want to see it, but here it opens in that straight area of the urethra. So this is a rectoprostatic fistula. And in this case, you probably have enough bowel. Remember, you always want to know if you have enough bowel for your pull-through. Now, what about this one? So here is the mucus fistula. Here's the distal bowel. This is the bladder. The bladder is very filled. What malformation is this? Perineal, no fistula, bulbar, prostatic, or bladder neck. And again, this is not a perfect lateral. You can see that the femur is a little opened, but you can see the sacrum here. You will have everywhere. Okay, I consider this a rectoprostatic fistula, and I knew that entering posterior sagittally, I was gonna find the rectum. I was prepared that this was not enough to bring it down, but surprisingly, in this case, it did reach. So I didn't have to take the mucus fistula down, but I was prepared for that. What about this one? This is the mucus fistula, and this is just bowel that you're seeing. Has plenty of bowel. So rectoperineal, no fistula, recto-urethral-bulbar fistula, prostatic fistula, or bladder neck. Everybody can vote. No fistula. Very good. This is a case of no fistula. I was present during the study. The thing is, when you have so much distal bowel, you have to inject a lot, and it's very hard to generate enough pressure. But I was able to get to the end, and it was a patient with Down syndrome, so I was confident that the diagnosis was probably that, and that entering posterior sagittally, I could find the distal bowel. What about this one? So we don't see the entrance of the mucus fistula, but that's the distal bowel, and that's the bladder. And that's the end of the sacrum, and that's the anal marker. So what malformation is this? Let's see what everybody voted. Very good. Majority said rectal bladder neck fistula. This is the case. You should not enter posterior sagittally. If you enter posterior sagittally, you're going to damage the urinary tract. You should enter through the abdomen to disconnect the urinary tract from the bowel from the urinary tract. I would say this is a case of a rectal bladder neck fistula. What about this one? Everybody can vote. Here's the mucus fistula. This is the bowel. This is the anal marker. Rectoperineal, no fistula, bulbar, prostatic, or bladder neck. Let's see the answer. No fistula. Very good. So in this case, you can see that the entire bowel is very distended. It's very close to the anal marker. You don't see extravasation of contrast, so you have no reason to suspect that this is a rectoperineal fistula, and you don't see any contrast in the urinary tract, so this is not a bulbar fistula. This is a case of no fistula. What about this one? So here is the mucus fistula. This is the distal bowel you're injecting, and this is the bladder. That's the anal marker. So perineal, no fistula, bulbar, prostatic, or bladder neck. I would say this is a rectoprostatic fistula. So here would be bladder neck, here is prostatic, and in the curve would be bulbar. Very good. What about this one? Perineal, no fistula, bulbar, prostatic, or bladder neck? Bulbar. Very good. So bladder neck would be here, prostatic would be here, and bulbar is in the curve. And here's another case that sometimes when we insert the Foley, it is easier to go to the rectum than to make the curve into the bladder. What about this one? Rectoperineal, no fistula, bulbar, prostatic, or bladder neck. So here's the mucus fistula. You can see you have plenty of bowel, and it ends here. What's the diagnosis? Bladder neck fistula. Very good. So it opens very high. There's no way you can reach this posterior sagittally. What about this one? Here's the mucus fistula. We inject contrast. It stops here. Rectoperineal, no fistula, bulbar, prostatic, or bladder neck. Let's see the answers. No fistula. Very good. So we don't see the urinary tract here, so it cannot be bulbar. Now, what about this one? Rectoperineal, no fistula, bulbar, or prostatic. We're injecting the mucus fistula and it ends right here. This is the bladder. Bladder neck fistula. Very good. This one you have to approach through the abdomen to separate the rectum from the urinary tract. What about this one? Rectoperineal, no fistula, bulbar, prostatic, or bladder neck. Let's see the answer. This one, we have some people saying perineal, some people saying bulbar. This is not prostatic, not bladder neck. Here's the bladder. And you can see the urethra here. Do you want to comment on this one, Dr. Peña?
See, in anorectal malformations, like in all kind of congenital malformations, you find anatomic variants, and this is one of those. See, you have to look carefully and look at the rectum here, and then this is the bladder, this is the posterior urethra, and this is the bulbar urethra right here. Yet the contrast material doesn't go into the bulbar urethra. The contrast material goes into something different, like a continuation of a long fistula parallel to the urethra and open somewhere in the penis. So this is like a double, this is the fistula goes parallel to the, and what to do about this? Well, don't panic about this. What our experience is that we repair the malformation and we divide this right here. And forget about this distal part. Just leave it there. And because it's connected to the urethra, it will drain. It will not give any symptoms, will not give any problems. Don't try to separate this continuation of the fistula from the real urethra, because all this looks very innocent here, but actually this tract is going through the spongiosum tissue of the urethra. And if you try to get this, you're going to get into a bleeding, massive bleeding, and you'll be in trouble with spongiosum tissue. So we open posterior saxal and we divide the fistula here. You just forget about that and bring the rectum down, and the patient will do well. So this is, you can call this a long, narrow fistula part. These malformations are not part of our classification. We put them in a bunch of malformations called complex malformations. There are many malformations like these. We have more than 100 of cases that don't fit into the classification, but Mother Nature is like that.
Okay, what about this one? So here's the mucus fistula. We're injecting contrast, and here you can see the bladder. So is this a perineal, no fistula, bulbar, prostatic, or bladder neck? Everybody can vote. This is a bulbar fistula. Very good. It's way below the coccyx. The patient has a normal sacrum, and it's at the curve of the urethra. Very good. This is a rectourethral bulbar fistula. What about this one? So you can see the mucus fistula, and you can see the bladder here. Perineal, no fistula, bulbar, prostatic, or bladder neck. This is a bladder neck fistula. So let's look careful. It's very important to know when it's a bladder neck, and you have to look, where's the sacrum? This is way above the sacrum. So you know you're not gonna find this rectum posterior sagittally. You have to look for it through the abdomen. So this is a rectal bladder neck fistula. Here's the bladder.
And this is the case in which the rectum will never reach the perineum, because the surgeon opened a very distal colostomy. So it's a very short piece of bowel here. A very short piece of bowel. Try to imagine to bring this all the way down here. There is no way to do it. And if you have to take down the colostomy, and then this part of the bowel is going to be located somewhere here. after the pull through, because this part of the valve will be down here.
So that's when you have to be prepared to have options intraoperatively. What about this one? Perineal, no fistula, bulbar, prostatic, or bladder neck. So here's the bladder. Here's the urethra. So let's see the answers. We're almost done. This is, you can consider a high bulbar or a low prostatic. I would accept both of them. Very good. But you know, posterior sagittally, you will be able to find it. What about this one? Bladder neck, prostatic, no fistula, bulbar. Everybody can vote. This is the mucus fistula, and this is the bladder. This is a bladder neck. Very good. So I think bladder neck, we got it. Let's move. What about this one? Perineal, no fistula, bulbar, prostatic, or bladder neck. Everybody can vote. This one, we only see the urethra, so it's a bulbar fistula. So here's the mucus fistula. We inject its contrast and it goes directly into the urethra. So, and here's the anal impression. So this is a rectourethral bulbar fistula, very low because you can see how close it is to the anal impression. What about this one? So here is the sacrum. This is the anal marker. They put the Foley a little too deep in the bowel, and here's the connection. What do you think this is? I would say this is a rectourethral bulbar fistula because you can see it's right at the curve of the urethra. It's very close to the anal marker. We're almost done. What about this one? Mucus fistula, distal bowel. This is the bladder. This is a classic one. This one, I'm not going to accept the wrong one. Let's see. This is a prostatic fistula. So here would be bladder neck. In the straight portion is prostatic, and in the curve would be bulbar. So this is right in the middle of a prostatic fistula. So this one, Mother Nature did it perfectly. What about this one? Finally, mucus fistula injection, and you see contrast right there. What's the diagnosis? Let's see the answers. Rectoperineal fistula, very good. So here you can see that it's opening right near the anal impression. Very good. Another one. Perineal, no fistula, bulbar, prostatic, or bladder neck. Everybody can vote. Very good. Rectourethral bulbar fistula. Here's the mucus fistula. You have enough bowel and it goes into the curve. Very good. What about this one? Perineal, no fistula, bulbar, prostatic, or bladder neck. Everybody can vote. We're almost done. This is a prostatic close to a bladder neck. Very good. So you have to be very careful when doing this surgery. It's a long distance. That's when a laparoscopy would be well indicated. Another one, we're almost done, I promise. Let's just finish very quick. Let's see what you vote. Answers. Rectobulbar, very good. Another one, this one you should know the answer. Let's see what's the answer. Perineal, very good. What about this one? Answer. Prostatic, very good. What about this one? You can see that it shows the urethra. Let's see the answer. Bulbar, very good. And what about this one? Let's see the answer. Bulbar, very good. I think we learned, and that's it. So thank you everybody for joining us today. I hope this has helped everyone with the distal colostograms. And if there is any topic that you want us to dedicate a full meeting onto it, just let us know and we'll be happy to do it. We'll see you next month. Thank you very much. Bye-bye. And sorry for being late.